Hello, my name's Sarah Wilmot. I'm a PhD student at Northumbria University. I don't want to say I'm in my second year yet because it's too scary, so I've just finished my first year. I'm going to be talking to you about my project, which is a realist evaluation of care planning in multimorbidity. But I'm going to be focusing today on phase 1 of my project, which was a rapid realist review. I have spent most of my first year kind of coming to terms with the methodology and developing my theories. So just an overview, I'll give you a little bit of a background to my study, talk about the study design. As I said, it's in 4 phases, and today I'm going to talk to you mostly about phase 1, the rapid realist review. So just a quick background. The number of people living with multiple long-term conditions is projected to rise by 1 million in over a 10-year period, which obviously is going to have huge cost implications to the NHS. At the moment, the way it works is when a person has more than one long-term condition, they'll go to separate review appointments, which obviously takes up a lot of their time and the practitioner's time, and it could be that the NHS is unable to cope with that rise as it stands. So this was proposed by the Year of Care Partnerships Programme. It's the House of Care model, so it's they've developed care planning which has the patient at the centre of the care, and they say that there's all these things going on outside of the house, the organisational processes, the commissioning, that have to kind of work together for care planning to be able to work. And the care planning is a one appointment which kind of brings all of the patient's conditions together, and they'll discuss everything that's important to the patient in that one appointment, and then they'll have a review appointment the following year, or if it's for diabetes then I think it's 6 months, but it really kind of means that the person can bring what they want to talk about to the consultation. They can obviously see their practitioner if they need to in between those appointments. But the person is at the centre, and it's a whole systems approach. So this kind of led me to developing my research questions through talking to practitioners. The care planning is being used, it's being rolled out now, it's been piloted in several areas, but it is being rolled out nationally. But people are doing care planning, but nobody actually knows what it is. They know what it's maybe what they're supposed to do, but we need to kind of get into the why is this working, how is this working, which goes on to my second research question, and obviously I'm focusing on multimorbidity, so that leads into my third question, my second as well. For whom does it work best? So this is my study design. The phase 1 is a rapid realist review, which I'll talk about in a little bit more depth soon. Phase 2 will be local focus groups with experts in care planning. That'll be people that are involved in the practical implementation of care planning and are also policy makers. Phase 3 will be a national Delphi study, and that will involve national experts in care planning. And then phase 4 will be testing the refined theories in practice. So at each of these stages, the programme theories that are developing will become more and more refined with expert knowledge. So the reason I've chosen to do a rapid realist review as opposed to a realist synthesis is because obviously time constraints with my PhD is a 3-year full-time project. Also, the literature is quite limited in terms of care planning and multimorbidity. So I'm going to be involving the expert stakeholders to kind of streamline the review process, and I've got one of my supervisors is actually the national clinical lead for care planning, so that really helps me to kind of take things back to him, and he can say, well, I think you need to look at this, you know. It just really helps me to streamline the review. The first step, I'm going to talk to you now about my realist review, my rapid realist review. This first part of the review started early on when I completed my initial project proposal, and that was developed through meetings with the national lead for care planning, and we agreed that because care planning is such a huge area with all the components around the house of care, we need to kind of focus it down to a manageable level. So this is kind of my care planning map that I've developed. As you know, it kind of goes round in a circle, and this is kind of being developed at my second time round the loop. So there was an initial map like this, but it was much less kind of, things were not as in their places there. And I envisaged that as my understanding of care planning is better as time goes on, and the arrows there will become thicker with the more kind of the greater links between things. And this really just shows the complexity of care planning and how there needs to be things in place from the commissioning side of it, the foundation, and the practitioners need to have time to then put into the IT systems, to then do a written care plan, to then go towards patient education. You know, everything, it's really linked, and this goes really well with the house of care model that I showed you earlier. We agreed that focusing down onto the actual care planning consultation would work best, keeping the patients at the focus, like the house of care. And then the second part of the review was developing the specific research questions which I went over previously, and then identification of how the findings and recommendations will be used. So from the beginning, we kind of agreed that the findings and recommendations would inform future practice, so I think it's important to keep that in mind as I'm going through the review. And this was the development of my search terms. It's just one example. I used the PICO model and I adapted it. I met with the information specialist at our university, and we decided that we'd switch comparison and control with context, because that would fit better with my CMO kind of configurations there. So this idea has come from a hunch through a little bit of background reading and through speaking to practitioners, and the search terms have been broken down obviously into population, intervention, context, outcome. And the reason I've used the context is because the PICO model was initially developed for a medical experimental research, whereas I've said this fits better. But on reflection, after my initial literature search, this was kind of a little bit too specific, and it wasn't really bringing back the results that I was looking for. So on my next round, I kind of went in with a more broad approach, and that was much more useful. So it was kind of good to have to go through the systematic searching. I did this for each of my CMOCs, and then it was my second time round I went in with a much more broad perspective, and there was lots more results that I hadn't come across before. So then number 5, part 5 of the review was the identification of articles and documents for inclusion in the review, and at each supervision session we've discussed the reference lists, and with having the National Clinical Lead for Care Planning on my supervision team, it was good for him to kind of say, well, I think you've missed a really important paper there. So and then the quality review, the experts, as I said, on my supervision team helped to identify key articles which accelerated the search process to ensure that I wasn't missing significant papers and sections of the literature, because it's a rapid realist review. And so this is just an example of the extraction of the data from the literature. This was for my first programme theory, which was about patients receiving their results before their review appointment. So they had chance to kind of look at them, take it in, and then they go to the appointment with an idea of what they want to talk about. So this kind of supports that hunch, which enabled me to develop the programme theory. You can see that the among the suggestions made, Northumbria Diabetes Service recommended that patients should be able to see blood and urine test results before their next review appointment to give them ample time to think of any questions. So that kind of fed into my my resource and reasoning part of the CMO. And there's my programme theory as it is at the moment. So the resources, the results are sent to the patient ahead of the care planning consultation, put in the context of the patient is engaged in the care planning process, triggers the reasoning, the patient has a chance to think about their health and formulate questions, and then the outcome is the consultation time can be used as purposefully as possible. Part 8 of the Rapid Realist Review is the validation of findings with content experts. So, as I said before, Phase 2 and Phase 3 will involve the stakeholders, the expert stakeholders there, and at each phase the theories will become more refined. So at the moment they're just kind of in their initial stage where they've been tested through the literature, but they will become more and more refined at each stage, and then they'll be tested through in practice at stage 4. So these are just some of the challenges that I've faced so far with the Rapid Realist Review. And that was, the first one was ensuring that the scope of the review remains contained. And as I said, because care planning is a massive topic, and there are things maybe that sit just outside of what I want to focus on, like peer support, which is a huge part of care planning, and how that can help it to work for the patient. But obviously, I just had to, that care planning map that I showed you really helped me to kind of focus and think that's outside of my remit. I need to really keep focused on what I'm looking at. Another challenge was that there is limited published literature, which again is why I said I'm doing a rapid realist review and why I'm involving expert stakeholders. And another one was organising the messiness and being transparent throughout, because I've used NVivo to kind of keep my documents and papers all together, but then I've got another separate working document which is transferring things across all the time, and so that's quite difficult to keep it making sense. And then my last challenge was the search terms were too specific versus too broad. So as I mentioned earlier, At first I had the PICO model, and it was really specific, and then I went really broad, so it was kind of, I went from one extreme to the other. So again, that was a challenge, and I had to go from little paper, like not very many papers, to having loads of papers. So maybe something more in between would be quite helpful. But yeah, any feedback or questions would be great. Thank you.